Hello, everyone. So we have Professor Mark Whiteley with us today, founder of the Whiteley Clinic. He is a consultant venous surgeon, and he is the founder of the College of Phlebologists. Did I say that correctly?
The College of Phlebology, yes.
Yes. Okay, so this is such an exciting interview because Professor Mark is actually going to tell us about all things veins and some of the syndromes, the pelvic congestion syndrome, which are all important things because sometimes we think that we know what is the cause of our urinary issues, and it could be in fact something else that's triggering those symptoms. So we're going to get into that. So we're mentioning pelvic floor, therapy and all these different things in this summit. It's like mostly the theme of this summit, and how people have kind of flown under the radar and getting this kind of care. But I want to talk to you about pelvic congestion syndrome. So how common is it?
It's very, very common actually, and it's one of those things that people don't know about, and it's been a difficult thing to try and bring into the medical arena. What we know is that when we talk about pelvic congestion syndrome just as chronic pelvic pain, we know that about 30% of women, that's 1 in 3 women who go to gynecologists or OBGYNs with chronic pelvic pain have pelvic congestion syndrome, and almost none of them get diagnosed. They all get told they've got endometriosis, or they get told they've got ovarian problems, or there's nothing wrong with them, and they get sent to psychiatrists. And that's because although the research papers have talked about pelvic congestion syndrome and pelvic varicose veins since the 1960s, even when I started presenting my research in 2000, people just didn't listen. And it wasn't until about 2005 and 2010 that my research papers started getting accepted. And we're now in the situation where it's just starting to take off, and every big veins meeting in the world now has a section on pelvic congestion and pelvic veins. What's very interesting though is most women, when they have pelvic issues, of course, go and see OBGYN or a gynecologist, and they aren't involved in the research of pelvic congestion. We invite them in, but they're not interested because it's not part of the traditional way of looking at women's problems. So we have this big disconnect to the problem where 1 in 3 women with pelvic pain, and then on top of that, 1 in 6 women with leg varicose veins, women with piles or hemorrhoids, and women with vaginal and vulval varicose veins. All of these things are part of pelvic congestion syndrome. And yet, apart from the phlebologists, the venous surgeons, very few doctors in the world are even looking at this.
Yeah, it's funny that you talk about the disconnect. I told you that I've been experiencing urinary issues since I was very young, since 2nd grade actually. And when I think about my journey, I've pretty much had issues with urinary health my whole life. I've always run to the bathroom. There's always been an urge incontinence going on. I've always had little accidents of leakage, and I even wet the bed until I was 10 years old. I played sports. I was a cheerleader and fell on my tailbone, even had a bruised tailbone at one point. I ran track, so I imagine, the gun going off and, the nerve. I thought it was just nerves, but then now knowing how things could be connected, with your veins and how it could trigger different points. So I mentioned I felt like it was the nerves, but what symptoms can cause pelvic congestion?
So pelvic congestion, I sit on the international committee called the UIP committee, and we've just published the consensus document, and I've just written a book on the for people to try and demystify it a bit, because one of the things that's interesting about pelvic congestion is it's a terrible name. Because when you say pelvic congestion syndrome, even doctors think, well, I wonder what that means, and they get unconfident. And the best way to think about it is firstly just pelvic varicose veins. So think of big varicose veins in your pelvis, pushing on the bladder, pushing on the bowel, pushing on the vagina, pushing on the walls, and that starts telling you what you expect. Now, we don't know quite why these veins cause problem. We don't know if it's a hormonal problem. We don't know if it's because of direct pressure. We don't know if it's because of stasis and little irritation of the blood on the inside of the wall. We don't know why. We just know that if you've got these varicose veins in the pelvis, they can cause problems. So in my book, what I've set it up is in medicine, we always think of things as either symptoms or signs or both. So the symptoms are either inside your pelvis, and that's irritable bowel, irritable bladder, discomfort on sexual intercourse deep inside, not too superficial, but deep inside, an aching or dragging in the pelvis when you are standing or sitting, which eases when you lie down, irritation of, as I said, the bladder and the bowel, which gives you your urinary or bowel symptoms, as we said. But you can also have symptoms outside the pelvis, which is the 1B symptoms. And this is low back pain or hip pain. So sometimes the pain inside the pelvis, the brain makes it appear on the outside. And we published some research showing that when you fix the pelvic congestion, hip pain quite often disappears as well. So people often are told that the pain in the hip needs a hip replacement or painkillers, and sometimes that's pelvic congestion. Then we go to what's called the signs, things we see. And that's much easier because symptoms are always people worrying, is it this causing it or that causing it? Whereas signs, it's obvious. If you've got bulging varicose veins of your vagina or vulva, if you've got bulging varicose veins at the tops of your legs on the inside, if you've got hemorrhoids, that's all definite pelvic congestion. If you've got veins across the top of your pubic area, where the pubic hair is, or up on the sides, that's a different sort of pelvic congestion. It's still pelvic congestion, but that's when the veins are obstructed, and so you get these big veins up higher on the abdomen. And leg varicose veins, as I said before, one in 6 women who have leg varicose veins have got it because of pelvic congestion. And most vein doctors don't check the pelvic veins. And one of the big reasons that women who have their leg varicose veins treated get their veins back in the future isn't that veins just come back. It's because they weren't diagnosed properly in the first place as having leg veins of pelvic congestion. So we have these sort of symptoms inside the pelvis or around the pelvis, and we have the signs of the bulging veins.
Yeah, so most of the time when women get the varicose veins removed, it's because it's unsightly and it's more like a cosmetic thing.
Well, it's a very interesting thing you say that, because that's certainly the common perception. And that's not absolutely true. If you look at it, we got my clinic, the Whiteley Clinic in the UK. We were looked at by what called the CQC, the Care Quality Commission, and the inspectors came to look at us, and they said, "Well, of course you're cosmetic, aren't you? Because you're varicose veins." But when you look at the number of people who come, you certainly do have a proportion of people who come with thread veins or varicose veins in legs, and only because they don't look nice. But if you start talking to them, a lot of them actually have aching and tired legs. And when the varicose veins are gone, that disappears. Even more of them are deteriorating through that aching and tired legs towards swollen ankles, then little red stains or brown stains around the ankles, some itching called eczema. And if you leave it for many years, you can end up getting leg ulcers. And in the past, people used to think brown stains or red stains around your ankles, swollen ankles, leg ulcers, and then, of course, clots and bleeds. People used to think that was all something different. That was deep vein problems. It turns out, actually, that's just leaving varicose veins for too long. So what in the UK, the guidelines called the NICE guidelines, and in America, you've got the American Venous Forum guidelines. They say that when you have got varicose veins and any symptoms, in other words, aching legs, tired legs, you should be thinking about getting fixed for medical reasons, not for cosmetic reasons. So there's this whole sort of issue that people think of varicose veins as just cosmetic, and they clearly aren't, because if you leave them, they deteriorate.
Okay, well, that's good to know, because my varicose veins actually run in my family. And I've always had veins that you could actually, see, especially here. And the doctors are always like, "Oh, this is easy," when they needed to draw blood. But now I know that it could be a sign of something. It could be a symptom of something else. And even further, like when you think of varicose veins, you think of immediately of the leg, because that's usually where they're located. But you mentioned that it can actually be in the genital area. So for women, that could be near their vulva. And how can those intimate varicose veins in the genital area be treated? Because when you think about the leg being treated, it's a lot easier to swallow. But when you think about the genital area, how do you do that?
And this is one of the problems that doctors have. And one of the things I always give in my lectures, and I've also shown in my book, is that if you think just logically of blood going from your toe back to your heart, anywhere that blood falls backwards is where the problem is. Now, it's only emotionally that we think, well, the leg, of course, it's only muscle and bone and skin, so that's easy. But when it's inside us, oh my gosh, that's a big problem now. So it's only our perception that makes us think that it's more difficult inside. It's actually, the physics is the same. Whichever vein has let us down, whether it's behind your knee, in your groin, which is the saphenous veins, or whether it's in your pelvis, your internal iliac vein, or whether it's your ovarian vein higher up, they're just veins that should be taking the blood back to the heart. But because of usually genetics, the valves have failed and blood falls down and causes varicose veins. So the simple answer is when you've got bulging veins in the genital area, lots and lots of midwives in the past and lots of OBGYN in the past have said, oh, wear tight pants or support. That's incorrect. To cure them, what you have to do is, like everything, you have to find out where they're coming from. So you don't treat the vein you see the same way that if you've got a varicose vein in your calf, you don't treat the vein you see in the calf. You do an ultrasound scan, you find the underlying cause, and then once you can know the underlying cause, we know which techniques to use. And that's what I've spent the last 20 years of my life doing, is identifying which tests are best and which test, and once you've got that test, which treatment is best. And one most important thing about veins is we learned a long time ago that when you lie flat, varicose veins disappear. So for instance, if you go to your doctor with a leg varicose vein and he examines you lying flat, he will say you haven't got varicose veins, but you stand up and they appear. But for some crazy reason, when it's inside you, so it's your pelvic veins, they lie you down on a CT scanner or an MRI and then tell you there's nothing wrong with you because you're lying down. And that's why, because this emotional idea that because it's inside you, you need to have an MRI or a CT is wrong. What you need is you need to actually be lying at about 45 degrees so the blood can still fall backwards down these varicose veins. And you need to have a specialized duplex ultrasound scan. And that's what we developed, a thing called the Holdstock-Harrison protocol. And that specialized scan can tell us which of your internal veins is causing the varicose veins on the outside. Sometimes it's just the veins on the outside, rarely, and then we can treat them directly. More often, there's 1, 2, 3, or 4 different veins on the inside, and depending which ones they are, we can then treat those.
Okay, that makes sense. If you are not in the right position, then absolutely they would go under the radar, and that's why so many people are misdiagnosed or not diagnosed at all. And we're feeling like, okay, I know that I feel this in my body.
Yeah.
I know that there's something wrong. I'm hurting, I'm in pain, I'm uncomfortable, but we're not given I don't know if it's like we're not given the time spent to really, get to know what's going on with us, because we're kind of like, okay, we got 10, 15 minutes with the doctor, and they look at your scans very quickly. And so it's very difficult to live with something that you're thinking is in your head.
Yeah.
Because you're being told, well, medically, I don't see anything.
And this is the trouble with commercialization of medicine, is what ends up happening is it becomes a conveyor belt. And when you have complex issues, especially when there's no internationally defined perfect test, you have to take each patient as they come. And so in my own clinic, people get half an hour to talk to the doctor, then they get a scan, which takes anywhere from 40 minutes to an hour and a half, depending how complex it is. Sometimes we have to split it into 2 with bowel preparation, and then another half hour as a minimum to talk through the different options. And often that isn't even enough, because these veins, they can be refluxing. In other words, they can be varicose veins with blood falling down because the valves aren't working. But more uncommonly, they can be blocked or they can be narrowed, and they have to be opened instead. And that's a
Right.
completely different thing. Still called pelvic congestion, but it's completely different. Now, the difficulty is, in many practices, patients are laid flat. They have an MRI or CT, and so doctors are saying, oh, there's a narrowing here or a blockage here. And it isn't that, actually. And if you stand the patients up and you move them around, these blockages disappear. And what they actually have is the varicose veins with the blood falling the wrong way down, which is a completely different treatment. So it's really, really important that you get to the bottom of what the patient's telling you about, getting exactly the right tests to make sure the treatment you're offering is correct. And also the patient understands the pros and cons of all the different issues there are with treatments. Because just because you have the right symptoms and also the right test doesn't mean to say one's causing the other.
Right.
And even in the best areas of my practice, if you look at all the papers that are written in pelvic congestion, most honest papers say that you get about an 80% success rate, but 20% of people, even in the best hands, we still don't cure because we still don't know everything about the issues, you know, what causes what. So we can hear the patient's problems, we can find out what's going on, and we can treat them. And usually one feeds the other, but sometimes they don't. And so you treat a patient and don't always get a perfect result.
Mm-hmm.
Plus, of course, nowadays everybody wants an instant result. And even though everything we do nowadays is done with pinhole surgery and local anesthetic, it's still, your body still has to heal. So you don't actually feel better after treatment, usually for a minimum of 3 months, and quite often up to a year later. Because just like major surgery, we have to remember that the body has to heal. So there's a lot of, one of the talk, I gave this talk yesterday in this international webinar, as I mentioned earlier, and I did actually, in the final slide, I said when we treat patients with pelvic congestion, we have to be really honest with patients, and we have to say, you know, this is what we know, this is the pros, this is the cons, and we have to say, you know, we are trying to make you better, but we have to work with you, and we don't just treat you and then say go away. We treat you and then we say, right, did we do better? And we follow you up, because we must keep making sure that we are getting on top of this and learning more and more about it as we go forwards.
Right. I mean, and so when you have an issue, if you're having some symptoms and you finally get it addressed and you figure it's the veins that's causing it, um, is it a lifetime that you then have to work on your veins and constantly keep up the health? Or once you address it, are you able to, you know, treat it properly and then give some relief, and then maybe if it happens again, you come back and for treatment?
Absolutely. I'm actually writing a book on this at the moment on treatments of veins, because most people who get their veins back again in the short term, whether it's leg varicose veins or pelvic varicose veins, is because the treatment they had wasn't optimal, to say the least.
Okay.
And it's often because the test that was done too quickly, or it's done as a routine, and you know, people were treated like they were standard rather than individuals. What we know in our legs, for instance, is most doctors still have about a 30% recurrence rate of leg varicose veins per year, because they don't look for pelvic veins, they don't look for perforators, they just treat the major veins. Whereas in my own practice, we've got it down to 3% per year, because we search for every single cause and treat them. The same in pelvic veins. We've published recently our 8-year results, and we get good results in the long term if we find the veins using techniques like the duplex ultrasound with the Holterstock-Harrison protocol, where the patient's not lying flat but at an angle. You find which of the 4 veins are at fault, maybe 1, 2, 3, or 4. We then treat the veins with what's called coil embolization. But what you'll find, a lot of people who only half do this, they will only treat the ovarian veins, the gonadal veins. They won't treat the ones deep in the pelvis. And so, not surprisingly, the patients don't get better because they haven't had all the veins treated. So if you find all the causes and you treat them with the most up-to-date treatments, and you get all of the causes treated, and you check and you stop the reflux, those veins on the whole, well, we know from our 8-year follow-up, those veins are treated. and you have a very small chance, about probably 3% per year, of a new vein opening up.
Okay.
But you really should only have that, and that's your genetic risk. And that's the same as someone who has never had a problem suddenly getting a varicose vein the next year. So in other words, it's just your risk of deterioration by being alive. If your recurrence rates are higher than that, it means that the original problem probably wasn't either diagnosed or treated adequately in the first place.
Okay, and that makes sense, because
I
if you
hope
don't,
so.
yeah, that makes sense. I mean, if you're not treating the right thing in the first place, then, you know, but just knowing that it's not like a life sentence
Oh, no.
of having the different treatments that you can, but also just knowing the options and knowing that you can check further than what has been told to you. And you have to trust and advocate for your own body when it comes to these things. I was surprised to find out that a part of maybe a gynecologist's study is not actually to be so intimately involved with that pelvic area. They, of course, they know the ovaries. Of course, they're familiar with your cervix and you carrying the baby and these different things. But the amount of attention that goes to that pelvic area is not as in depth of a study as you would think, for a gynecologist to have when they're dealing with that area.
I think what's really, really interesting, because I used to, when I was at medical school, I was thinking of becoming a gynecologist at one stage. And what was very interesting is gynecologists are absolutely superb in the area that they look at, which is, the pelvic floor and the organs and the nerves and all the things that are obvious. But the thing that everybody forgets is veins, because they're part of the connective tissue. And so, for instance, we have this ridiculous situation where we still have bowel surgeons treating hemorrhoids. Well, they're veins. We have urologists treating varicose veins around the testicle, for their veins. We have gynecologists ignoring veins around the uterus. They say, oh, have a hysterectomy rather than treat the veins. And loads of women are told the only thing they can have is a hysterectomy when the pelvic congestion's got too bad. And the gynecologists who I've talked to about this, quite often they'll say, oh, there's nothing wrong with this patient. And we'll say, well, we found pelvic congestion. And I'd say, well, when you did a laparoscope, didn't you see big veins? And they'll say, oh, they've all got that. And they just dismiss it, because the trouble with veins, they've never been taught that big veins in the pelvis are a problem. So they see the problem, but they don't understand that that's the problem, because what they're looking for is tumors and fibroids and things that they're trained about. So it's a perception problem where veins are really part of the connective tissue, and as such they're not as interesting as an organ like an ovary or something.
Right.
And because it's not come out, so this is one of the things I would set at the College of Phlebology, is to try and say, if it's part of your venous system, it's all linked: hemorrhoids, erectile dysfunction, varicoceles, all this pelvic congestion syndrome, all these different things, and leg varicose veins, venous leg ulcers. These are all part of the same misfunctioning venous system, which we're not getting on top of because it's been fragmented off to other specialities. And these other specialities are more interested in the organs rather than the connective tissue or the veins that travel between them. And this is sort of the area we're in at the moment as researchers, of trying to get the education out there to other doctors and nurses to explain it without trying to put their backs up. Because, of course, when you try and explain this, the first thing they say is, well, I do a brilliant job, and they get angry rather than say, let's put the patient first, and perhaps we should be. And so it's a difficult difficult path to tread at the moment.
Yeah, I'm trying to zip it a little bit, trying to hold back a little bit. I mean, I couldn't agree with you more. I just wish there was, a way to bridge the gap, and instead of being offended or defensive about, the suggestion, why not work together and, try to figure out how you can be of service to the patient. Because at the end of the day, that's what you're supposed to be doing.
And I think you're doing exactly the right thing. And I think you see, I think the medics, we go to conferences, we argue, we go to journals, we argue in the journals, and the people who haven't been involved until social media came along and until people like yourself have started getting in, we've almost ignored patients. You know, patients, you're just statistics when we do studies, but that shouldn't be the way around it is. You should be turning around and telling us if we're doing a good job or not. And that's not just this patient satisfaction surveys, you know, was our coffee nice? Did we greet you at the door? That's not right. What's important is the registry data. Were you happy with your service? Were you happy with your treatment? Not just when you leave the office or the hospital, but 1 year later, 2 years later, 3 years later. That's the key. And it's only by this interaction and webinars such as you're doing here that we actually get the feedback that we need to know. There's no point in doctors saying, I'm interested in this. What we should be saying is our patients need us to be interested in X, Y, and Z.
Absolutely. And I mean, I know that you have a heart for it and a heart for your patients and actually giving them the treatments that they need and deserve at the end of the day. So what are some of the treatments that are available for pelvic congestion syndrome?
Well, the first important thing to say is that usually patients who have got very mild pelvic congestion syndrome never even get to see a phlebologist such as myself, because some people have such mild symptoms that they can be treated with just some simple hormone tablets. And some people are given some, there's a couple of different progesterone type tablets that can help. Once you've got quite large varicose veins in your pelvis and pelvis reflux, if you're getting either the symptoms that we discussed before or the bulging veins, the signs, you have to do something physical. And we are looking at a new device and a technique that is probably not going to come up for a few years yet. So at the current time, what seems to be the best is to do a local anesthetic procedure where you go through the neck with local anesthetic, you pass a catheter into the varicose veins, you inject foam sclerotherapy, which destroys the veins, but if you only do that, they tend to reopen. So then away from the delicate organs, you then put a coil, which is a metal coil that irritates the vein and permanently closes it. So the combination of the foam and the coil seems to give the best results at the moment. There are other techniques as well at the moment, but that's at the moment seems to be the best. Now, there is something else to say. Some patients, and luckily it's only about 2% of patients in our series, although other specialists think it's more, they have what's called May-Thurner syndrome or Nutcracker syndrome or Nivel, which is where the vein, instead of refluxing, in other words, blood flowing down and bulging, is blocked. Now, in those cases, you have to use what's called a stent to open the veins. The difficulty with the stent is if you're opening a vein, you have to keep it open for the rest of your life. And that's much more difficult than blocking a vein. So when we do a coil embolization and foam, the chances of a good result in the long term are much, much higher. Whereas when you put a stent in, you then for the rest of your life have to worry about keeping that open and do you take anticoagulation or not. So I think if you need a stent, of course you need one, there's no problem. But I think you have to be really, really careful that you need one before one's put in, because once you put one in, that's a life commitment. And so you need to be certain of it. And just having an MRI or an IVUS, an intravascular ultrasound, saying it looks narrow, in my book isn't enough. You need to really make sure that there is a good pressure difference and there's a good history. And if there is, then of course a stent is fantastic. What I think every expert would agree now is that then you shouldn't be offering more aggressive surgery, things like hysterectomy, until until you've absolutely exhausted every other possibility. And really, in pelvic congestion, that shouldn't ever be an option. So if you need a hysterectomy, it means you've got something else going on there. We can now cure most people if it's true pelvic venous congestion with coils and foam sclerotherapy.
Well, that's good to know. At the beginning of this year, when I was hospitalized, I had a deep vein thrombosis. And the medication that I was given seemed to make my bladder even more overactive than it was before. I had gotten a UTI that lasted over 2 weeks. And I was certain that I was going to need surgery to, pretty much pin my bladder back into place. But it was through those struggles and in my research and trying to find relief and treatment and support for what I was going through that I discovered that, in fact, I didn't need to get surgery. But had I gone and said, hey, I want this surgery, I'm tired of dealing with this, I could have done more harm to myself than good. And the reason I even created this summit was to get people to understand what their options are, the solutions that are out there, the treatments that are out there. And it doesn't necessarily need to be surgery. But I mean, if it is the case of you having to have surgery, you do need to know that you still need to be proactive about caring for yourself and making sure that you have done all the research and all the looking into things that might be causing it, especially the veins, because you don't want to end up in a place where you've had this surgery and now you're still getting some symptoms of something because the underlying issue had to do with a vein and not your bladder or not, something in that pelvic area. So to me, I find comfort and relief in what you're saying, as that can be an option for treatment. And then we talked about, we're talking about, finding out if it's a vein. So what test can we ask for? What tests should we, suggest, if it's not suggested to us, because a lot of times it's not. We're left to kind of figure out things for ourselves. So what should we ask for? What can we ask for?
So in the venous world, the gold standard test is a thing called a color flow duplex ultrasound. And so it's like in the ultrasound you'd have for a gallbladder or for a baby. So that's your black and white ultrasound. So you can see the pelvic organs and the veins. But it also has what's called Doppler or color flow. So this isn't Dopplers like you'd do on a leg to see if you've got good blood flow at the ankle. This is it's like the big television, the big sort of color flow duplex. And what you do is, if you do it properly, and there's different ways of doing it, but what we've developed in our clinic is a way where we do a transvaginal Doppler duplex ultrasound. The probe goes into the vagina or at the entrance of the vagina, because then you can see all the veins at the lower end of the pelvis, because that's obviously where they're affecting. And then the patient should be lying at about 45 degrees. So in other words, not flat, but not bolt upright, about halfway. And then you can ask the patients to strain or to cough or to squeeze their buttocks and let them go, called the Kegel squeeze. And what you should see is, with the color flow, you should see the blood flow up the veins. And in a normal vein, it doesn't come back down again because the valves stop. If, on the other hand, the valves aren't working, you see the blood flow up the vein, and then you see it rush back down. And that's a vein, that's a varicose vein, one that's going wrong. You can also see the size of the veins, you see the blood milling around. And that's the very most basic test to really see whether things are going on. Now, there are people who do transvaginal scans but don't use the color flow. They literally just use the black and white and look for bulging veins. You can do that, it's not so accurate. There are also a lot of people who do transvaginal scans with the patient lying flat. And again, that doesn't really help. They ask patients to do the Kegel squeeze or the Valsalva, the heavy breathing to push the blood down. But it's much better to use gravity. Going backwards from then to sort of tests that aren't quite so good, you can do the same color flow duplex but across the abdomen. If you need to do that for some of the different tests to look for nutcracker and May-Thurner syndrome, but it's actually, if you don't do the transvaginal bit, you will miss a lot of the lower end, which is where all the action happens as such. So really the basic test that I think most people who are experienced in this area would now look at for is a transvaginal duplex ultrasound scan with a patient at 45 degrees. Now, on top of that, there are some other things that you might need to do. That's the basic, though. After
Okay.
that, you could use, so say if the lady is unable or unwilling to have the transvaginal scan, or you're doing a man, or if there's any reason you can't do that, then you have to go for a second best. And the second best would be across the abdomen with a duplex scan and probably an MRI. But with that, you have to really be looking carefully and trying to know that you're not getting the most accurate test, and you have to put more together in your mind and say, well, I think that's probably going here and going there, and with what you've found on examination. There are other tests you can do as well. You can do venograms, which is the traditional one. It's not the greatest sort of test. The trouble with venograms is it uses X-ray. The contrast you use, people say dye, but it's a contrast. It's heavy, it's cold, it doesn't flow like normal blood. It only goes where you squeeze it. People still like it because doctors like it, I mean, because they sort of see the veins. But the trouble is not as good as duplex ultrasound. We proved that in the legs in the 1990s. We're fighting the same battle now in the 2020s, proving what we already know, because it's the pelvis. Other people, there are other techniques you can use, like IVUS, which is intravascular ultrasound, but that only looks for narrowings. We can also do things called plethysmography. So there's some more sort of complex tests we can look at. But the standard test now for pelvic congestion when you're starting is the transvaginal duplex ultrasound with the patient at 45 degrees.
Okay. All right. Well, you heard it here. You do have options. You do have to advocate for yourself. And you do need to do a little bit of research, especially if you've been to a doctor and they've, you're going undiagnosed and your symptoms and your pains are going under the radar. There are other things that you can look into and that you can consider when you're trying to communicate with your physician or healthcare provider. Now, Professor Whiteley is actually the founder of the Whiteley Clinic. So could you tell us about some of the things that you're doing at the Whiteley Clinic and how you're advocating for your patients?
So one of the things we obviously do, we're putting things out into the media as much as we can. So we've published a huge amount on pelvic congestion syndrome, both how to diagnose it. We've won quite a few research prizes as well to show that people who are told they have nutcracker syndrome, for instance, you can do a simple test with ultrasound where you lie the patient one way and it looks like they have nutcracker syndrome, but if you just tip them the other way, the actual gravity opens up this narrowing and it disappears. So we're sort of showing how we can, some of the things that we think we know about in the medical world, we can actually find our ways around if you have an open mind and also a sort of a way of sort of thinking. We've got some research coming out at the moment. We work, obviously, I'm the founder of the College of Phlebology as well as the Whiteley Clinic. So through the College of Phlebology, a lot of doctors are now starting to join, and we've got a thing called the Venous Registry. And what this means is when we treat patients, we put all the information into the registry anonymously. The registry encrypts that to keep it anonymous, but also puts their email address in as part of that encryption. And then without anyone knowing what it is, it automatically emails the patients every year to check whether everything still works. So what it means is we can go back year after year after year and find out if what we're doing is working in the long term. Not because we say it is, but because the people who matter say it is, and that's the patient. And over the years, the more doctors that join it and the more different techniques that are put into it, the more we will start to build up a really good picture of what's working and what's not. We're trying to look at we've got some doctors have started suggesting different ways of classifying pelvic congestion, and we're starting to look at whether those work or not. We're trying to increase the way we have the algorithm of taking people through the current diagnostic tests. And we're also looking at the moment at some quality of life issues and also a new technique, which we hope will eventually be able to treat people with pelvic congestion syndrome by destroying the veins, but without leaving metal inside them. Because a lot of people don't like the injection of foam sclerotherapy and then metal coils. And although they are very safe, there still is that very small risk that they might move. in the short term. It doesn't happen in the long term. They are very safe, but people worry about having metal in them. So we've got a new technique which we're hopefully bring out over the next few years, which will actually take away that risk. So the whole world of sort of pelvic congestion syndrome is huge at the moment, and whether we're looking at the diagnostic side, the patient satisfaction, and the registry side, or the new ways of diagnosing and treating it, there's so much going on at the moment. It's a phenomenally interesting area. I must say one other thing you said earlier, which I think was very interesting, was when you said that you don't jump straight in for surgery. And I think you're so right. As doctors, I'm very old now as a doctor, and I was taught a long time ago by my forefathers that it takes 3 years to learn how to operate, but a lifetime to learn when not to operate. And you should never resort to big surgery until you've exhausted all the other options.
Thank you for saying that. That's so important to know, that you don't have to, choose the surgery just because that, you've gone 40 years like me, not having any relief or being properly diagnosed. I mean, even having the conversation with my physician, there were never any other probing questions. If I went in and I had a UTI and I said, hey, I have a UTI, okay, we'll test to see if you have the UTI. If the test came back positive, here you go, here's some antibiotics, but there was never any further questioning. Do you have any other urinary issues? Are you having incontinence? How often do you get UTIs? Those kinds of things were not asked to me. And certainly not the suggestion of getting any kind of, testing done or anything like that. So I think it's important that what you do is at the forefront and really spoken about, so that people do know that these are things that you need to look out for as well, or that you can look into to find out if in fact this is causing some of your pains. So Professor Mark has actually written a book, and he's actually offering something to the audience today. Can you tell them what you have for them?
Yes, there's a downloadable version of the book. It's a couple of the key chapters in it to help people understand the introduction to it and also the end of it, so that they can sort of get a feel for what pelvic congestion syndrome is all about.
Yes, so just click the link below to take advantage of that. And also, please, I encourage you to follow the Whiteley Clinic and the College of How am I going to say this? Phlebology. How funny. Tongue twister. And really research and find out about this, so that you can advocate for yourself and even your child if you see these symptoms. And even we didn't really get on the subject of men, because we're focused mainly on the women, but men do suffer with these issues as well. So if you know someone that's suffering with these issues, make sure that you are checking for all the things and not just the one thing, and concentrating on the one big thing. So Dr. I'm sorry, I keep calling you doctor.
That's quite all right.
Professor Whiteley, thank you so much for joining us, and we hope to see you soon.
Thank you. You're welcome. It's been great talking to you.
Thank you.
Thank you.